The study I'm presenting at ASCO is called eRAPID, which stands for Electronic Patient Self-Reporting of Adverse Events, Patient Information and Advice. And it's an eHealth intervention. The study was supported by National Institute for Health Research of England program grant over quite a few years. And the intervention has several components, and I think it's important to explain those components and how it differs from other similar studies and other similar applications. We have developed over the years with research support an online questionnaire for patients to report their symptoms. And then we included an element of clinical algorithm, which is behind the symptom reporting. And that clinical algorithm is based on our current clinical rules that we use. And also we worked extensively with colleagues and patients. And that algorithm can then provide advice to the patients, which comes immediately after they complete the questions. And it tells them how to self-manage some of the mild to moderate symptoms and when to contact the hospital. And then a further important element of our eRAPID intervention is that the results are then immediately displayed within the electronic records, so clinicians can view the reports without having to log into a separate system. But as they open the electronic records for that patient, they can see that data as well. And finally, if patients report severe symptoms, they get a kind of a red alert to say, you seem to have a problem, please contact the hospital. But also the clinical team will get an email alert about that. And also when we started testing that intervention, we've just introduced across England the acute oncology care. So we added our intervention to acute oncology, and acute oncology means that patients who are on treatment are provided with hospital contact number, or hotline that they can ring 24/7. And if they need admission or medical assessment, they go directly to that oncology team. They don't go via A&E. So patients already are receiving good care, and we added to that further monitoring. So this is kind of the intervention, which we then tested in a randomized trial of over 508 patients precisely, who were starting chemotherapy for early breast, early colorectal cancer, ovarian cancer of any stage, and later we added metastatic breast and colorectal cancer. And our main outcome of interest was better symptom control. So we expected that we'll see better symptom control in patients who are self-monitoring and following the advice that they were given. And we did see that, although we powered the study for finding a difference 18 weeks, which is towards the end of the chemotherapy, whereas when we did our modeling and statistical analysis, we actually didn't see differences at 18 weeks, but we found differences at 6 and 12 weeks. So patients who used the online intervention had better outcomes, better symptom control at 6 and 12 weeks. And we measured symptom control by a standard questionnaire, functional assessment of cancer scale, their physical well-being scale, and it covers common side effects of treatment. We also hypothesized that if patients receive immediate advice and they follow that, or if they're prompted to contact the hospital, that will help with patient education and will help them to self-manage the symptoms better. So we included questionnaires on self-efficacy and confidence in managing symptoms during cancer treatment. And in one of those questionnaires, a 6-item scale, we found improved patient self-efficacy. So we could kind of hypothesize that the intervention works through the regular recording, but also patient education and increasing patient confidence as well. We monitored, obviously all of that comes with a concern, will that increase the workload? Will clinicians be overwhelmed by alerts, etc.? So we monitored all of this, and we didn't find an increased number of hospital calls, no differences in admissions, acute admissions to the hospital, no differences in other consultations with the nurses. So that's reassuring. We monitored patient safety as well, and there weren't any issues with that at all. It was safe to use that application and that intervention for patients. And another outcome that we looked at, we wanted to see whether there will be any differences in the chemotherapy, dose changes, modifications, delays, etc. Again, we didn't find differences in those parameters. We were interested, obviously, moving forward, which were the components, elements of that intervention that worked well. We ask patients to complete the self-monitoring questions once a week at least, and we send them reminders. Also, the system was open, so if they had a problem, we encouraged them to complete before it's, as it's happening. So we monitored that patient adherence, and we found good adherence over 70% most of the time. And then we looked at what might determine this adherence. So patients who had slightly higher or less symptoms at the start of the monitoring adhered better. Older patients, again, adhered better than the younger patients. And we also looked at if clinicians used the information patients are providing, the reports during the consultations. We had kind of extra monitoring, asking the clinicians to complete a short form. And we found an association between the clinicians using the reports during the consultation and patients' adherence. So if clinicians were using the information and discussing it with the patients, then patients were more likely to adhere to the intervention. And that came through some of the interviews we did with the patients who said, yes, it was very helpful. The doctor used it, they opened it and talked to me about it. Whereas some other patients said, well, the doctor didn't look at it and ask me the same questions, and then I stopped doing it. And then we also asked the question, well, if the patients are more adherent, does that matter? And we looked at subgroup analysis, which actually showed that patients who were more adherent had better symptom control on the FACT questionnaire. So that's kind of in a nutshell the results. What does it mean and what is different from other studies is usually a question I'm asked. So I think the innovative components of the intervention was that linking to the patient advice immediately as they report their symptoms, so patients immediately get something back. What also patients found very important is that then this information was shared with the clinical team. And I think that what makes this intervention different from the variety of apps that are now available. You can download on your smartphone and monitor the symptoms, but it's not kind of linked to the clinical team and doesn't provide the information. So I think that's something, again, quite important for patients. Then this is the largest study, to the best of my knowledge, that includes patients with early cancer who receive chemotherapy with a curative intent. Majority of the studies in this area that have been very influential were done in advanced cancers, and they have shown benefit in terms of symptom control and survival benefit as well, which was really very encouraging and kind of opened the interest in using this more widely. But we haven't had enough data in the adjuvant setting. And actually, this is where the majority of the chemotherapy is delivered routinely. So if we could add something that will help patients more without increasing the workload, that is really quite an important result from our study. I'm kind of, certainly for our setting in Leeds, I'm prepared to make the case to actually roll it out in routine care. I think we've done enough studies and we have evidence it helps patients. We have the system set up, and I think it's probably time to roll it out in routine care with kind of pre-planned audit to see if we're getting similar results. And I think it's time to roll it. There's also an important element around how you train clinicians to use the system. It's pretty, it's not difficult to use. You just need to click on a tab, and then clinicians learn quickly how to interpret the scores. that basically map on the common toxicity criteria. So that's pretty straightforward. It's more encouraging clinicians to use it, that it will save them time, that it will provide them information which they otherwise have to spend time getting out from patients and asking about their symptoms, and patients may forget about symptomatology. So I think there's a barrier there to overcome with clinicians, and we have the data that if clinicians use the system, then actually it is better for the patients and the results are better. And I think we probably have a window of opportunity in the current COVID-19 situations where we have moved very quickly to telephone consultations to kind of avoid that direct contact. And actually, if I had the system up and running, that would have been a lot better. We have a very small team in our cancer center looking at lower gastrointestinal cancers who used our setup and developed their own questions for kind of longer term follow-up of their patients. And they have started emailing me saying how useful it was with the telephone consultations to actually have some formal recording of patient symptoms. So I think we have a window of opportunity to introduce those remote monitoring measures in medicine and in our cancer population, like we are talking in many other areas, of course.